A 45-year-old woman presented to the emergency with a 4-day history of a painful right eye associated with photophobia, lacrimation, and blurred vision. She gave a history of having similar episodes of pain in the right eye previously. On general examination, she has small raised vesicles on the eyelid and chemosis of her right eye. Slit lamp exam showed linear branching ulcer in the upper right eye that stained green with fluorescent dye. What is the most likely causative organism?
Sir, herpes simplex
Herpes simplex
virus.
virus.
That is correct.
Dendritic
Because
ulcer.
dendritic ulcers are characteristics. Along with that, you can find that there are small vesicles which are present along the eyelids. That is also quite characteristic of the herpes simplex virus. A 70-year-old Caucasian woman visited the eye clinic complaining of distorted central vision that came on rapidly over the last 2 weeks, along with straight lines appearing wavy when reading. What is the most significant predisposing risk factor for the likely eye condition? What is the eye condition that the patient is having and most likely risk factor?
Straight line appearing wavy. Yes. Oh,
What is the patient suffering from?
Myopia, sir.
70-year-old.
no, smoking.
In myopia, do you see distorted central vision?
No,
Sir, senile
maybe optic neuritis. The case is maybe optic neuritis.
Optic neuritis. Okay. Do you see this straight line which appear wavy in optic
That is
neuritis, or
against.
is there
That
total
is
loss of vision?
against. That is against. So central macular. Okay, macular degeneration. Yes.
That is the
Smoking.
condition. So what is the
Smoking is the cause. Smoking.
most
Family history.
significant? It is not linked to family.
Macular degeneration sounds nice.
Macular degeneration is what is happening over here. So what is the most significant risk factor?
So I think it is smoking.
Smoking.
Hmm.
Okay. So what they are asking is the most significant predisposing risk factor which would predispose the patient to developing this condition. Uh, Smoking is actually a risk factor, but what you can put it in the
Then
category of a
age more than
modifiable
60
risk
years.
factor. Yes,
Then
so age
age.
is
Age.
an advanced age puts the patient more at risk of macular degeneration. So that is the correct answer. And smoking is the most modifiable risk factor. Okay. So because the predisposing risk factor is not necessarily the most modifiable risk factor, that is why the answer changes. Had this question been what is the most significant modifiable risk factor, then definitely smoking would have been the answer. 45-year-old woman presented to her general practitioner because her partner had noticed that her right pupil was larger than her left. On examination, she had abnormal pupillary reflexes as below. So these are the different responses to consensual reflex and accommodation reflexes for the left and the right pupil. What is the most likely diagnosis?
These people.
Sorry?
Leave tell me sir, these people.
Okay, anyone else? So, doctor, can you tell me what is the cause of this 𝑨𝒃𝒐𝒖𝒕 people?
This is the
So 𝒕𝒉𝒆𝒄𝒌 people is actually the correct answer, and it is caused because of denervation of the ciliary muscles. Okay, this is the muscle which is responsible for the reflexes in the eye. They supply the iris. They are around the iris. They help in the contraction of the iris with regards to when they are exposed to light and things like that. So if it is associated with an absent and a knee reflex, absent knee and an ankle reflex, this is called as
You are not audible, sir.
the right eye. On examination, he had a right eye with a fixed, small, oval right pupil, blurred vision on the right side without any staining of the cornea with fluorescent. What is the most likely diagnosis?
Acute anterior uveitis.
I think.
Anything else?
Glaucoma.
Why do you say glaucoma, doctor?
Fixed pupil is also there.
Okay.
Painful loss of vision.
Sir, acute ankylosing glaucoma, no stain over the cornea and fixed pupil and acute condition painful.
So there is only a small technical difference because of which it is not glaucoma. In glaucoma, you get a semi-dilated pupil, not a fixed and a small pupil. You will get a fixed pupil, but you won't get a small pupil. You will get a semi-dilated pupil. Because it is mentioned that it is a small pupil, that is why the answer becomes an acute anterior uveitis. Otherwise, the reasoning that you have given is actually very true. Okay. Year-old man was brought to the neurology clinic by his wife with complaints of reduced mobility, poor concentration, and short-term memory loss for the last 6 months. She also revealed that he suffered from visual hallucinations during the aforesaid period, and in one episode, he had recently seen his dead mother on several occasions in the house. He was experiencing difficulties with his mobility for approximately 12 months. He was much slower and walking, and his strides had shortened. On occasion, she said that he shuffled. His past medical history of urinary incontinence was possibly attributed to prostatic hypertrophy. He was a non smoker and drank 6 units of alcohol in a week. He was alert but easily distractible. He scored 21 by 30 on MMSE, deficiencies in visuospatial tasks and frontal executive tasks. Blood pressure is normal and on standing. Pulse is 67 regular. He had marked dysarthria and perseveration. Cranial nerve examination normal, slightly reduced facial expressions. On upper limb examination, bilateral rigidity, bradykinesia, but no resting tremors. On examination of lower limbs, there is marked rigidity and appeared to walk with a slow, festinant gait with poor turning and reduced arm swings. This is the investigations. 12 lead ECG showed sinus rhythm and a ventricular rate of 69 beats per minute. What is the most likely diagnosis?
So want to see the scenario again. This is normal pressure hydrocephalus. Short-term memory loss, urinary incontinence.
Does NPH explain the visual hallucinations?
No. Bilateral rigidity bradycardia.
Do you want to see the options?
Yes, sir.
So what is the answer, doctors?
So dementia with Lewy bodies.
That is the correct answer. So from the clinical scenario, the things that you have picked up are that he has short-term memory loss, there is visual hallucination, and he has features of Parkinson's. This is the typical triad of dementia with Lewy bodies or frontotemporal dementia. Okay. A 40-year-old truck driver presented to the medical admissions unit with increasing incoordination and loss of movement in the left arm over the past 7 weeks, along with decreased mentation and confusion. His wife states that he frequently made long trips which made him stay away from home. He also had a use of chronic alcohol abuse and promiscuous relations. An MR scan shows 0.1 to 1.5 centimeter lesions in cerebral hemispheres in white matter and gray-white junction which suggest demyelination. A stereotactic biopsy is performed and immunohistochemical staining of the tissue reveals JC virus, JC papovirus, and oligodendrocytes. Which of the following lab test findings is most likely to be associated with these?
Sir, D. Oligoclonal band in CSF.
Oligoclonal band.
So what is the diagnosis for this?
The
Multiple
multiple
sclerosis.
sclerosis.
Why do you say so? Look at the time duration. The time duration is 7 weeks. And also remember that there is decreased mentation and confusion. Multiple sclerosis generally only in very late stages do they affect the mental status or the higher mental functions.
The CD4 count.
Okay, so what are you suspecting?
It's disease. Viral.
HIV. Who's in favor of HIV?
Right there, it is mentioned that he has a history of promiscuous relations. Does that
Yes. CD4 lymphocyte count 90 per
correct?
microliter.
So because of his profession, him being a truck driver, staying away from home for long periods of time and having promiscuous relations, he is at increased risk of HIV, and the condition that the patient has is progressive multifocal leukoencephalopathy. Because JC Papova virus or JC virus is not generally seen in immunocompetent patients. They are generally seen in immunocompromised people. So a CD4 count of less than 90 or a CD4 count of 90 means severely immunocompromised. Hence, that fits with the current clinical scenario and the diagnosis of PML. Okay. A 55-year-old man was brought to the medical admissions unit by his wife with the following complaints. 1 month ago, he had been fired from his job after making inappropriate sexual comments to a secretary. Moreover, after losing his job, he bought a new sports car and had apparently not considered the financial implications. His body weight has increased and he has gained over 30 kilograms in weight over the last 4 months. Such indiscriminate behavior on his part had been worrying his wife for the last 8 months. He, however, had no speech impairment or motor dysfunction. His BMI was 33. He appeared disinhibited and was easily distracted with marked perseveration. He scored 23 upon 30 on MMSE with deficiencies in attention and calculation and naming. Visuospatial function was preserved, cranial nerve was normal, peripheral nerve showed a left palmo-mental reflex. However, the muscle tone, power, reflexes, sensations, and coordination are all within normal limits. Cardiovascular is normal. These are the investigations. An EEG was done, which is normal. MRI is again shows normal study apart from an atrophy of the right frontal lobe. What is the most likely diagnosis?
Lewy body disease because frontal this atrophy of right frontal lobe. Yeah.
Okay. Again, does he have any features of visual hallucinations? Anybody wants to give the answer?
Huntington's.
Is there any history of abnormal limb movements?
So if we exclude all the probable options, then only the remaining option is Peak's disease.
If that is the correct option. Okay. So Pick's disease is frontal dementia, and the pathognomic feature is atrophy of the single frontal lobe on MRI, which is present in this patient. Okay, inappropriate behavior is usually the presenting feature of this disease. This is not Lewy body dementia because there are no Parkinson features and there is no evidence of visual hallucinations. Okay, whenever you read about visual hallucination in any question, that is a pointer towards Lewy body dementia. Last couple of questions. 25-year-old woman with a history of epilepsy since the age of 6 years was admitted to the emergency with a 3-day history of worsening generalized headache associated with vomiting, unsteadiness of gait, and blurring of vision. The unsteadiness had progressively worsened over the last 4 weeks, and his speech had started to become slurred during the last 2 weeks. She has lost 8 kilograms within the last month, along with feeling nauseated and tired, and attributed to pressure at work. She has visited various ophthalmologists for multiple angiomas of the left eye. Her current medications include phenytoin, carbamazepine, and the oral contraceptive pill. On examination, she appeared unwell. Speech showed marked dysarthria. Blood pressure was 150/89. Pulse was 69. Fundus examination revealed bilateral papilledema and evidence of previous photocoagulation. She has reduced visual acuity in both eyes. However, pupillary responses were normal. The rest of the cranial nerves are normal. Upper and lower limb tone, power, reflexes all appeared normal. There was a marked bilateral intention tremor and past pointing in the finger nose test and heel shin test. She has a broad based and ataxic gait. Sensory examination appeared normal. Chest normal. Abdomen there was a palatable right kidney. These are the investigations, which are mostly normal. Only red blood cell count is high and hemoglobin is markedly high. Urine analysis shows blood present, urine present. MRI scan shows bilateral similar cerebellar hemangiomas. What is the most likely underlying diagnosis? So what is the syndrome?
Sir, B. Von Hippel-Lindau syndrome.
Okay. Anybody else has any different opinion or answers?
Yes, Arpit and Tales.
So that is correct. So there are the following things which are mentioned in the clinical scenarios. The patient has got cerebellar hemangiomas, as a result of which he has got cerebellar signs. There is history of retinal angiomas. The patient gives a history of having had multiple episodes of photocoagulation, and she has developed renal cell carcinoma because of palatable right kidney and presence of urine and blood in her blood and protein in her urine. She also has polycythemia, which again goes in favor of renal cell carcinoma. So this triad is present in Wall-Hippel-Lindau disease. A 20-year-old man fell down while playing hockey. He presented to the emergency with a large hemarthrosis in the right knee. These are the investigations. Hemoglobin is slightly low. INR is okay. Prothrombin time is okay. APTT is high. Bleeding time is normal. Factor 8 activity is normal. What is the most likely diagnosis?
Von Willebrand disease.
Anyone else?
Large hematoses. Okay, it may be the hemophilia.
Which one, doctor?
In von Willebrand disease, there is no large hematoses. This is the patient is having large hematoses. So maybe hemophilia B.
Hemophilia B. Anything in the investigations you find to be odd and correlating with one of the
Activated
diagnoses?
APTT 68.
Yes. So that is associated with
Factor
there
7
are a few
deficiency.
conditions it can happen.
Yes, but factor 8 deficiency also can do this high APTT level.
The factor 8 activity is normal. The option is factor 7.
Yes, Factor 7 deficiency does not cause high appetite.
Correct.
So hemophilia B, and
That is
in case of von
Yes,
Willebrand disease,
this
it is
von
basically
Willebrand or
gum or mucosal
hemophilia
bleeding
B.
is there, basically not high large hematosis will be there. So it
Yes,
probably hemophilia B is.
hemophilia B.
that is the correct answer and that is the correct reasoning. Please take a screenshot of this. You can expect one or two questions from this particular slide during your exam. Okay. Moving to the last question for the session. 70-year-old man returned from a month holiday in Pakistan. He had fever, weight loss, and loss of well-being for the past 4 weeks. He is a known smoker, 28 pack year history. He was previously diagnosed as CLL 2 years ago but received no treatment. On examination, he has a temperature of 101 and palpable cervical axillary and inguinal lymphadenopathy. Pulse was 110 beats per minute and blood pressure is 110 upon 64. On abdominal examination, there is presence of splenomegaly. Investigations show pancytopenia, reticulocyte count is normal, LDH is high, CRP is high, urine analysis is negative, and a chest X-ray is normal. So, what is the
CLL
diagnosis?
may transform into lymphoma
Okay, why do you say so, doctor?
because, sir, I want to see the scenario. This whole man with CLL, that's chronic lymphocytic leukemia. So there is tendency to go to lymphoma, this transformation to lymphoma.
Okay, anybody else have a different opinion?
Tuberculosis,
History of traveling
right? Last
Yes,
crisis
could
is
be
right.
infectious mononucleosis.
Mononucleosis is not right. Not right. Lymphoma.
infectious mononucleosis, you would not see generalized lymphadenopathy,
No,
you would see
yes,
lymphadenopathy, which is basically restricted to the cervical region.
yes. And leukostasis stasis also not there. It's not
Okay,
does not match.
somebody mentioned TB, which is a very valid scenario. Okay, but you would not expect to find splenomegaly along with all the
Yes.
lymphadenopathy in TB. So, the only thing which explains all of the above findings is transformation into
Lymphoma.
lymphoma. Okay. So the other complications which you can expect are hypogammaglobulinemia because of abnormal B cells. This can lead to secondary immunodeficiency. There can be low platelet count, which is again which is present in this patient, and because of hyposplenism also you can note that. Autoimmune hemolytic anemia is also a possibility, although reticulocyte count is normal, and you can have other malignancies in this patient such as breast, colon, lung, and etc. Okay,
Okay, sir. Thank you.
thank you for your
Thank
time.
you, sir.